Hello, everyone. My name is Chanel Blackwood, and I am the marketing manager at iHEA. Welcome and thank you for registering for today's webinar, Child Health and Human Capital. Today's webinar will run for approximately 60 minutes and will be recorded and uploaded to the iHEA website afterwards. Before we begin the webinar today, I just wanted to run through a couple of housekeeping items. If you experience any technical difficulties during today's webinar, please type the difficulty into the chat box at the bottom of your screen, and I will happily assist. Everyone on the line has been muted except for our speakers today in an effort to eliminate background noise. We will also be holding all questions until the end of the session when we will open for a facilitated Q&A. Feel free to use the raise your hand function if you would like to ask your question verbally. I will now pass things over to Stavros. Stavros, over to you.
Thank you very much, Chanel. Thank you. And thank you to our speaker, Janet Curry. Janet Curry is the Henry Putnam Professor of Economics and Public Affairs at Princeton University and also the co-director of Princeton's Center for Health and Wellbeing. She also co-directs the program on families and children at the National Bureau of Economic Research in the States. And in 2015, she was named as one of the top 10 women in economics by the World Economic Forum. Janet's also served as the president of the American Society of Health Economics. Janet will be very well known to many of the participants in this webinar for her work on the economic analysis of child development. And she's going to be speaking to us today about child health as human capital. So we're going to be following the standard format where Janet will be giving a presentation for up to about 50 minutes and will allow time at the end for questions and comments. So thank you very much, Janet, for giving up your time, and we look forward to your presentation.
Thank you very much, and thank you for inviting me. So as Chanel said, I'm going to talk about the idea of child health as human capital. And so I think it's helpful to start off saying, well, what is human capital? If you just look in the dictionary, you get a definition like this, that it's wealth in the form of money or other assets owned by a person or organization or available for a purpose such as starting a company or investing. Or a shorter definition would be a valuable resource of a particular kind. So when we think about human capital, it's a particular form of wealth that's embodied in people. Now, economists have studied this for a long time, usually focusing on education as the most important form of human capital, which generates income as well as other returns like better health or life satisfaction. Child health was conceptualized as something that might affect these other outcomes, but mostly through its impact on education. However, increasingly, child health has been recognized as an important form of capital in its own right, one that may contribute importantly to inequality, and one that doesn't follow exactly the same processes as education. So what I'm going to talk about in this lecture is talk about some of the highlights from the recent literature. I'm going to explore an extended example of a policy intervention to extend child health insurance in the United States and its effects on health and inequality. And then I'm going to talk about some directions for future research, including a greater focus on mental health. So to begin at the beginning, one of the first things that economists really started looking at in this area was the importance of fetal origins or fetal period. And this literature is now very well established. It generally focuses on the effect of shocks like pollution exposure or nutritional deficits or maternal stress that happen during the period in utero. And one reason why this has been a popular area to explore is because the time involved is so well defined. If you know when somebody was born, you know approximately when they were in utero, and you can look at things that might have happened during that time. I think one of the important takeaways from this is that the older literature about nature versus nurture is really not a very well posed question, because nature and nurture interact. The same shock can affect different people differently depending on their genetic inheritance. And economists, moving on from here, are then increasingly focusing on early childhood. So, looking just as an example of this interaction between nature and nurture, this is from some work that I did with Enrico Moretti, looking at the relationship between mother's birth weight and child's birth weight using all of the data on births for California. So we have mothers who were born sometime after 1970 and children born sometime after 1989. What you can see is that there is a relationship between mother's birth weight on the x-axis and child's birth weight on the y-axis. But there's two lines here. One is for mothers who lived in the richest areas, and the other is for mothers who lived in the poorest areas. And you can see there's a pretty consistent gap. So even given whatever the mother's birth weight is, the child does better if the mom is in a better environment. So that's an example that shows that the same sort of inheritance has a different effect depending on the environment. So just to give a brief conceptual framework, we could think about the health of the child depending on some scale factor A, and then investments, I1 in the first period, and investments I2 in the second period, and you could have more than 2 periods. Here I've put a bar over I1, which indicates that you could think about, by the time somebody's born, the investment in the fetal period has already been made, and then the question is, okay, what should I do in I2 in terms of investments? So we assume that parents maximize some utility function. There's a set of prices, P, and depending on the amount of substitution between period 1 and period 2 investments and the other parameters here, you could get that the effect of a shock, which is the mu, so if the effect of the shock in the first period could be positive or could be negative in terms of what the parent's investment will be. So just a comment on this kind of framework is that there's several parameters here, and there's also the prices. Social programs can affect both the parameters and the prices. And the same investment then can have different effects depending on things like, well, where are you on the production function to begin with? Are you on a flatter portion or a steeper portion? So I think a takeaway from this is that you should expect to see heterogeneity in the effects of shocks and also heterogeneity in the responses. And there's a lot of different margins here for policy to affect outcomes. A second takeaway is that in the traditional human capital model of Michael Grossman, when you have a shock, it depreciates over time. But in this case, the effect of early life events might not depreciate. They might be reinforced by investments, and they could even grow over time. So you could get increasing inequality rather than decreasing inequality. So I'm going to talk now about an extended example that's illustrating these heterogeneous effects. So this is a public health insurance program, Medicaid, for low-income women and children in the US. Eligibility for these groups was greatly expanded beginning in the late 1980s And these expansions had different effects on poor and minority children than other children. This also gives us an opportunity to assess the value of having public health insurance. So just to give some context, Medicaid is by far the largest U.S. social program affecting children. Here it's compared to the Earned Income Tax Credit, which is a credit for low-income families, and the Supplemental Nutrition Assistance Program, or food stamps. And the way that these extensions were implemented meant that different states had very different changes in the fraction of people that were eligible. They started with different levels of eligibility, and then they were all brought up to the same level, which meant much bigger changes in some of the places that are shown here in darker colors. The net result of all of this was, as I said, very large expansion. So if you look in terms of something like pregnant women who were eligible, it went up from a little over 10% to more than 40%. And today, about half of all births in the US are paid for by public health insurance. So I did some of the initial work looking at this and found that it had an immediate effect on infant mortality, and some of that was explained by reductions in things like delay in obtaining prenatal care. But there's been some really exciting work recently that exploits the fact that these children who were born between 1990 and 2000 are now young adults. So we can look and see, well, what was the long-term effect of getting health insurance coverage? This table or graph is showing results from a paper by Miller and Weary that looked at a large range of outcomes in a lot of different data sets. And the point I'm trying to make here is that if you look at the blue bars, you can see if you look at the effects on all children, you see that the blue bars show that there was a fall in the number of chronic conditions and a fall in the number of hospital visits per 1,000. But if we look at poor children, we see bigger effects on those two outcomes and also effects on a larger range of outcomes, such as increases in income, increases in the probability of ever attending college, decreases in the probability of using this nutrition program, and interestingly, improvements in the Kessler Index of mental health. This expansion covered pregnant women, but also children, and you can use a similar type of identification strategy looking at the fact that it was phased in across places. And also there's a discontinuity because only children born after September 1st, 1983 were eligible for the expansions. And a lot of papers have shown that this has had a positive effect on these young adults. This is another take on showing that there's a lot of variation in the impact of these expansions on children. Looking at it by age, you had increases in the probability of being eligible going from 15 to 20% up to almost 50% for the youngest children. And in some work, I've argued that this is related to reductions in mortality among that group. So one way to see this is to do a comparison between, say, the US and Canada. Canada's arguably a reasonable comparison country, similar in terms of wealth, technology, things like vehicle miles driven, which are a major cause of accidents. But a big difference is that Canada's had universal public health insurance since the 70s. And then in the US, you had this large expansion for children. You already had old people being covered by a different program, Medicare. And then until the Affordable Care Act, the people between childhood and old age were generally not covered by social insurance. Okay, so we can look at this mortality comparison for the US and Canada, and the way that we do this is by ranking areas from richest to poorest, grouping those areas into groups that each represent about 5% of the population, and then do that for different census years and compare the mortality in each group. So that's a little abstract, but let me show you how it looks. If you look at the top left corner for age 0 to 4, this is showing along the x-axis the poverty percentile. So here 0 are the richest places and 100 is the poorest place. And then on the y-axis we have mortality. Okay, so these lines are generally all sloping upwards, which says that mortality is higher in poorer places. Now there's a lot of lines here. The blue ones are for the US and the red ones are for Canada. You can see that the lines for Canada for this 0 to 4 group are much flatter. So that's showing that there's less inequality in mortality in Canada than in the US. And then there's also a comparison for each decade. So this top line is showing child mortality in 1990, and then the next one down is for 2000, and then the next one after that is 2018. Okay, so what you can see is that there was this huge decline in mortality, which was greater in the poorest places, so that the line became flatter. It's still a lot higher in the poorer places than in Canada in 2018, but a lot of the gap closed. You see a similar kind of pattern for 5 to 19-year-olds. Okay, so these are the two age groups that got coverage. And then for the 20 to 49-year-olds, you see a little bit of a decline between 1990 and 2000, but then no change at all between 2000 and 2018. Again, for the 50 to 64-year-olds, not much change. And then for the 65 plus, who also have public health insurance, you see declines. Okay, so basically for the two groups, children who got coverage and old people who had coverage, you see big improvements in mortality, and then nothing for the group in the middle that didn't have public health insurance. You see a similar pattern for males. So the Medicaid expansion seems to have reduced mortality and improved health among poor children. You can also show that it reduced inequality among survivors. So using administrative data, you can look at these long-term effects, looking backwards at these cohorts who were affected by shocks in the prenatal period or early childhood. And one fascinating study that's done that by Brown, Kowalski, and Lurie actually uses income tax data. So they can look at people who are affected by these health insurance expansions, follow them up, in this case to age 28 in income tax data, and see how much tax are they paying as a function of whether they were covered or not. So what this plot is doing is saying, okay, let's take as time 0, age 19, and we're just going to normalize everything so the amount of tax you pay there is 0. And then we're going to say, if we go forward by age, how much does our tax payment increase as a function of where we were in the income distribution. So you see that the group that was becoming eligible for public health insurance has a much greater increase in the amount of tax that they're paying than groups that were less likely to be eligible. Okay, so some of this increase in earnings may be coming through improved mental health as well as physical health. If you look at conditions that young people are hospitalized for a surprising number of those people are hospitalized for mental health conditions. And this is one of the most important determinants of adult outcomes, especially because it affects working age people. Now, we know that many mental health problems may first show up or become really problematic in late adolescence or early childhood, but the origins of those conditions may be as early as the prenatal period. And in a way, economists have been talking about this for quite some time, because when we talk about non-cognitive skills, a lot of those non-cognitive skills are related to mental health. So to take each of these points in turn, child mental health problems are very common. This is US data that's put out by the Centers for Disease Control and Prevention. And they say, just in terms of ballpark rates, that about 7% of children currently have ADHD, 3.5% have behavioral or conduct problems, 3% have anxiety, 2% of depression, and then there's also some people that have autism spectrum disorders. And we also know, unfortunately, that suicide is a leading cause of death for teenagers. These are rates of people who currently are saying that they have something. If you look at the rates that are ever diagnosed, those are quite higher. Like for depression, it would be more like 12%. And these are all rates taken some time ago and long before the pandemic, where people are worrying a lot about what the effect of that has been on mental health. So as I mentioned, many non-cognitive skills are related to mental health. So just for an example, a paper by Per Anders Eden looking at Swedish data where draftees were tested, looks at non-cognitive skills including social maturity, psychological energy, intensity, emotional stability. Those four things kind of map into different types of mental health problems. So, for example, if you have autism spectrum disorder, that impairs your social abilities. If you have ADHD, that's characterized by a lack of ability to focus. If you have depression, you may lack internal motivation to do things. And if you have anxiety, you may not have very much stress tolerance. So you could think of mental health as sort of somewhat a continuum of these types of characteristics. Now, in terms of the cost, some estimates from the OECD is that this is quite costly in terms of a percentage of GDP. One reason for that is the loss of employment. So this is from the Eurostat database looking at differences by country in probability of employment for people with depression and without depression. But it could also affect your productivity on the job. This chart is showing for people who are employed in the US, the number of days in the past 30 days where people report that their mental health was not good. And you can see the rates are quite high. So for example, if we look at people who are reporting that in the last 30 days they had 10 plus days where their mental health was not good, it's between 10 and 20% of respondents. So as I mentioned, these problems often begin in childhood and continue into adulthood. And so recently people have been trying to see what impact early child mental health conditions have on future outcomes. In some work with Mark Stabile, we used linked administrative data from Canada to examine the effects of child health conditions on young adults. And we tried to compare the impact of some common physical health conditions like asthma and injuries, which are among the most common things affecting children, to some common mental health disorders, and specifically ADHD and conduct disorders. So we had about 50,000 Canadian children from the province of Manitoba and their siblings, so we could compare children to their siblings. And then the kind of outcomes we could look at were whether they used welfare after age 18, whether they were in a grade that was appropriate for their age, whether they were taking the courses in high school that they would need to go to college, and so on. So just to focus on one of those outcomes, whether you got social assistance or welfare after age 18, what this plot is looking at are just plotting out coefficients. So these are all estimated effects of having a particular diagnosis at a particular age. And so what you can see from the orange line is that having a mental health condition is more highly associated with being on social assistance after age 18 than either of these two physical health conditions, which really actually have quite small impacts on that outcome. Similarly, if we look at the effect on taking the college preparatory math that you need to be able to go to university in Manitoba, there's a very large negative effect of these mental health conditions, and again, a relatively small effect of physical health conditions. As I mentioned, these conditions can start quite early, and there's a range of literature now that's linking prenatal conditions to poorer mental health. Some of the earliest research on this was from the Dutch hunger winter, where you could identify the cohorts who were affected by the Nazi blockade of parts of the Netherlands during the war, and then follow those cohorts over time and compare them to cohorts who were in utero either before or after that event. And it's been shown, for example, that those cohorts are more likely to have schizophrenia. Another paper looking at, again, a sort of short, sharp shock of the Six-Day War in Israel also found increase in schizophrenia. Now turning to something a little less dire, people have looked at Scandinavian registry data and compared twins, and they find a strong association between birth weight and ADHD, even if you look at identical twins. A nice paper by Petra Pearson and Maya Rosen-Slater uses Swedish registry data and looks at the death of a close maternal relative during pregnancy. A nice thing about this paper and this sort of innovation is that having a death in your family is not actually random. People from lower income backgrounds and less educated backgrounds are more likely to suffer that kind of a loss. So in this paper, they compare those people who had a death in the family during pregnancy to people who had a death in the family just after the pregnancy, which arguably is a good control group. And they found that if it happened during the pregnancy, then the probability that the child used an ADHD drug increased 25%, and the probability that when that child grew up, they used drugs for anxiety or depression rose by 13% and 8%. So this raises a question: if this is a particularly vulnerable period, is there something that we could do to prevent future mental health problems by supporting pregnant women? Now, if you recall, I just showed you some data that said that as a result of this Medicaid expansion and pregnant women being covered by health insurance, we found improvements of the Kessler mental health scores among children. Another example, in some work that I've done with Anna Chorney, we looked at prenatal participation in a different program called the Supplemental Nutrition Program for Women, Infants, and Children, which offers nutrition but also helps people connect with medical services. And we looked at the relationship between maternal participation in the program during pregnancy and the mental health of their children when the children were 6 to 11 years old. And what we found was that there was a reduction in the incidence of mental health conditions. ADHD is a big one, but also other mental health conditions that are common in childhood, excluding ADHD. And these effects tended to be larger for African Americans and also for low-income people. In this particular study, we didn't find any effect on depression and anxiety, but I think that's because of the age group. We were looking at 6 to 11-year-olds, and those are usually diagnosed a little later. So what I'm showing is that we've already done some things that support pregnant women and seem to have an effect on the mental health of their children. But everything we hear about child mental health sounds like it's getting worse. And so I think it's important to address that issue. And one thing to keep in mind is that diagnostic standards for a lot of conditions are changing. So for example, when you see statistics talking about how autism has gone way up, it's important to realize that when we talk about autism now, we're talking about a spectrum of disorders, whereas before there used to be a distinction made between autism and Asperger's, for example. But there's also an issue that there are changes in health insurance coverage, changes in incentives facing providers, less stigma, more knowledge. And so if people have more access to care and they get screened more, then you're going to find more cases, even if, so it's going to look like there's an increase, whereas actually it's an improvement because you're finding people who wouldn't have gotten any help before. So just to show an example of that in the US, there's been increases in prescribing for ADHD. So that's this blue line at the top that is sloping upwards. But if you divide that up by insurance, it seems like it's mostly accounted for by people on the public insurance, which is the red line, and then people with private insurance, the line's pretty flat over this particular period. So what was happening in this period to drive increases in prescribing in the public health insurance group? Well, there was a switch from a fee-for-service program to a managed care program, where you had an organization that just got a payment from the government and then was responsible for all of the care. And these organizations were responsible for doing screening. And they also had incentives to do screening because they got a higher payment if the child had a disability of some sort. So we look at the effect of this switch, again using the data from South Carolina. And we do this with two different strategies. One is an event study where we're just looking at all the children in the 2 years before and the 2 years after the switch to managed care. And then we can also follow individual children. So you have the same child, and then you see, well, are they more likely to be diagnosed with something after their insurance changes to this managed care model? So the event study is shown here, and I've put the probability of getting a well child screening and the probability of being treated for ADHD on top of each other, so you can see how well those things line up. So this is an example where if you do more screening, you find more cases. If we look at the same child and what's happening with them, we see that they're more likely to have a well child screen. They're more likely to have a developmental screening. They're actually more likely to get vaccinations, which is surprising because they were always eligible for vaccinations, but now they're more likely to get them. And they're even more likely to have visits for sick incidence. Looking at increases in diagnoses, we see increases in mental health diagnoses, here ADHD and depression, but you also see increases in diagnosis for physical health conditions like asthma, infections, ear, nose, and throat, autoimmune disorders. So this is just showing that depending on the form of health insurance people have and the amount that they get screened, you may find more cases. Okay, so we've been touching on the issue of whether you can prevent mental health conditions, how they're diagnosed, and I want to just say a little bit about treatment, which is an important area for research. And I've been focusing here a lot on the US. It's been sort of a laboratory for understanding the effects of health insurance because there's so much variation within the country that you can use. And in the same way, there's a lot of variation in treatment. And there's also increasing availability of administrative data that allows you to take advantage of that to look at outcomes. So just to illustrate variation in practice style across different locations in the US, this map is showing county level data. So each square is a county. And it's the number of prescriptions of antidepressant drugs per 1,000 persons 10 to 19 years old in 2014. So here, the darkest shading is places that had almost one prescription per person. These are 30-day prescriptions. So if you had, one person could account for 12 in the year if they had continuous prescriptions all year. But still, that's almost one per person, down to places that had 0. So there's huge variation. Some of these places are right next to each other, indicating it's not at the state level, it's at a very local level that you're seeing this variation. So in some recent work, I've been trying to look at this variation and how it's related to outcomes for children who were privately insured for at least 1 year between 2012 and 2018, who had a first episode of depression or anxiety between ages 10 and 17. And we look at variation in treatment using measures of provider supply, like do you have a psychiatrist in your area, do you have therapists in your area, and also practice style, which is how physicians tend to treat different types of illnesses. We look at the outcomes at 3 months, 12 months, and 24 months after the initial episode. And so we're considering first spells because these children then are not already having some kind of treatment. If a doctor is seeing somebody who's already being treated in some way, then one option is just to continue the treatment that they're getting, even if it wasn't what the doctor would themselves have chosen. So we look at the treatment that they get for these first spells and then say, are they consistent with the kind of guidelines that are out there? And there's a lot of different guidelines. In the UK, there's the so-called NICE guidelines that specify pretty specifically what people should get. In the US, the guidelines tend to be more from professional associations like the American Academy of Child and Adolescent Psychiatrists. And then there's also some guidelines that are implicit in the fact that a drug is FDA approved for a particular use or not. So the FDA is the Food and Drug Administration in the US, and it approves drugs for specific uses and specific age groups. Now, for children with mental health problems, there are a pretty small number of drugs that are approved, which reflects the fact that most of these drugs haven't actually been tested in children. So, for example, for adolescent depression, there's only one drug that's FDA approved. So what you see then is a lot of what's called off-label prescribing, which may follow some professional guidelines, like these guidelines that are put out by things like the American Academy of Pediatrics or the American Academy of Child and Adolescent Psychiatrists. And so we're going to refer to that as gray area prescribing because it's not FDA approved, but it does seem to follow some kind of professional guideline. And then there are people who prescribe things that are not FDA approved, are not mentioned in any of these professional guidelines. And those are things like prescribing older generation antidepressants, just prescribing antipsychotics to people who don't have psychosis, or prescribing addictive drugs like benzodiazepines, which are not recommended for children. So we refer to those as red flag drugs. So we have three different categories of prescribing. So looking at the sample, we can compare the children who had any kind of mental health problem in our sample of privately insured children to the full sample of children that meet all the other sample inclusion requirements. And what we see is about 10% of children have a first mental health episode over the period of time that we're following them. Girls are slightly more likely than boys to have those problems. The problems tend to appear at around age 12, and they may be manifested in a hospitalization or an emergency room visit, but most of the time the first episode is going to be some kind of mental health evaluation. And then in our smaller sample of people who have anxiety and depression, you can see the same characteristics. You can also see, looking at outcomes, that the kids in the mental health sample are more likely to be hospitalized. They're a lot more likely to have some kind of self-harm, more likely to go to the ER, and then they have about double the monthly healthcare costs. And then you can also see that in this full group of people who have any mental health condition, a lot of it is accounted for by depression and anxiety in some form. So then looking at how people get treated, we see that if you follow people for 3 months after, say, the initial evaluation, about 75% of them get some kind of treatment in that period. A lot of them are getting therapy, and then about 10% are getting therapy and drugs. 18% are getting drugs, so that means that there's about 8% who get drugs and no therapy. And then you can divide the people who are getting drugs into those that are FDA approved, those that are in this gray area, and those that are red flag drugs. And then you can also compare what the outcomes look like for that group. And you can see, for example, that the costs are the highest for people who are getting the red flag drugs. Also, the probability of having an ER visit is higher, the probability of having self-harm is higher, and the probability of being hospitalized is higher. So just the means suggest that there may be some important consequences of this type of prescribing. When we actually do the estimates and look at what the consequences are, we try and summarize our results in this kind of a flow table. And you can think about there being a sequence of events. So first of all, are you treated within 3 months? Yes or no? What you see is that the probability of self-harm here is actually higher for the people that get treated than for the people who don't get treated. And this is the instrumental variable trying to take account of the fact that treatment is endogenous and that the people who are treated may be different than the people who are not treated. So what we're really looking at here is the marginal people who got treated because they had more providers in their area, or their providers were more likely to provide treatment. Okay, so that's kind of disturbing. But then we can ask, all right, if they got treated, did they get mental health drugs, or did they only get therapy? Okay, and if they got mental health drugs, the probability of harm is actually a little bit lower than if they didn't, if they only got therapy. And then we can divide up this group and say, okay, well, if they got drugs, what kind of drugs did they get? And what we see is that the red flag drugs are associated with a high probability of self-harm, whereas the FDA-approved drugs are associated with a much lower probability of self-harm, which in a way is not surprising, because that's one of the things that the FDA pays particular attention to, is whether a drug could cause some people to have increases in, say, suicidal ideation. And then these gray area drugs are somewhere in the middle on this outcome. If we look at effects on cost, what we see is that you have a slightly different ranking. So here the red flag drugs are very expensive. The FDA-approved drugs are also expensive, and the gray area drugs are much cheaper. Okay, so some sort of preliminary conclusions about mental health treatment. I think maybe one of the most striking things about our study is that we see that so many children are receiving treatment that does not conform to professional guidelines. A lot of this is actually children who don't have any evidence of psychosis getting antipsychotics, which have metabolic effects that we might be worried about as well. Another thing that we discussed was that improving attention to child mental health screening and also improving the quality of treatment could then be a promising strategy. So the flip side of saying that a lot of children are getting poor treatment is that that's some low-hanging fruit where we could improve treatment a lot and improve outcomes. And it's important to keep in mind that if we do more screening, we're going to find more cases. So the fact that you see cases going up is not necessarily bad news. It could reflect the fact that people are paying more attention and that more people are getting help. Another comment about this is discussing mental health very naturally leads you to focus more on adolescents. And we generally know a lot less about the effects of health problems in adolescence than we do about health problems in early years. And that's because a lot of the research has focused on early childhood. So as a result, less is known about adolescent health and its relationship to adult outcomes. And this is important because if we knew more about which measures of adolescent health accurately predict adult outcomes, then it would be easier for us to gauge the efficacy of some early childhood interventions, because we wouldn't have to wait till people are 30. We could say, oh, this early intervention has effect on this adolescent outcome. We know these adolescent outcomes predict adult outcomes. And so it would just speed up that process quite a bit. And we also might be able to target interventions more effectively. So one of the unknowns here is that it may be that the return to intervening in adolescence is smaller than the return to intervening in early childhood, but it could still be more cost effective to target interventions to adolescents who need them than to have a universal program for all preschool children. So I think the jury is still kind of out on that question. So just to conclude, there's really been an explosion of literature demonstrating that child health is an important form of human capital. We know now that healthier children live longer and healthier lives, but they also get more education and earn higher wages. They're more likely to be employed. And yet, we're just starting to unravel the mechanisms. The evidence shows that public policy can relax some of the constraints on investments and promote the development of children's health human capital, and there may be multiple ways to do that. So I will stop there and would be very pleased to take your questions.
Thank you very much, Janet, for the excellent lecture. That was tremendous. Thank you very much. So we now have about 10 minutes for questions or comments. So please, if you'd like to ask a question, please feel free to raise your hand. Alternatively, you can enter your question using the chat function. So Taiwo, would you like to unmute yourself and ask your question?
Sure, can you hear me?
Yes.
Great. Thank you so much, Dr. Curry. I work in a center where we often consider adolescents. We actually have a department within there. And I think as we think of those interventions that could be cost effective, our biggest limitation has been the very few interventions with adolescents you can take independent of some approval from adults and parents, for example. So we've targeted a lot of interventions at schools, and there are limitations within schools as well, because then you have to have some supportive environment either within the school district or the school system to be able to have those interventions. I'm just curious to know if you're working in this area to narrow down interventions that could be targeted towards adolescents that are cost effective, or what the future of this work might be in terms of improving adolescent health and then the gains in the future that we might be expected to see. Thank you.
So I think you're echoing in a way what I was saying is that we don't know as much as we need to know about interventions that would be helpful for adolescents. And there may be a lot of barriers to implementing those. I have been just starting some work looking at schools in South Carolina, where the state government has had a big push for their sort of local mental health centers to provide clinicians to schools. So I'd like to evaluate what the impact of having the clinicians be right in the school is on the sort of schooling attainment, but also mental health outcomes for the children. As I say, we're just starting, so it's going to be a while before we can see anything, but I think that might be a promising intervention. There is a precedent in the case of clinics that offer birth control in schools where they can give birth control to teenagers without necessarily getting consent from the parents. That depends a little bit on the state law, so it's different in different states, but that has been done before. So I think you're right to point out that adolescence is sort of this gray area in the sense that the parents may be involved, but the child may also have some autonomy, and there are areas where children have autonomy in at least some jurisdictions.
Thank you. Are there other questions or comments? Suchita, would you like to come in?
Yes, thank you. Thank you for this great presentation. I had two questions, and I apologize if you answered them during, but the first one was about your poverty data in the early piece of your presentation. Is the the county where they currently reside? Is it where they're born? Is it like an average of counties based on how, where they've lived over their lifetime? I was just curious about that. And then the second question was for the mental health data related to interventions in pregnancy. Were those data adjusted for the parents' history of mental illness? And you may have again shared this, but thank you.
Okay, so on the first question, when we were looking at changes in mortality rates by the poverty status of where people lived, I guess I should have said that was actually the location where they died. So on the mortality data, the place of residence at the time of death. So that would be the location that we would be using for people. And unfortunately, we don't have their whole history. So we don't know, if they were born in a poor place and moved to a richer one, because that's not in the mortality data. But just to be clear, what we're saying is that people who lived in a poorer place have a higher probability of death than people who are living in a richer place. In terms of the evidence showing that things that happen during pregnancy affect the mental health of the next generation, it depends a little bit on the studies. So for example, in the Swedish study that I was talking about with Petra Pearson and Maya Rosen-Slater, they can control for the parents' history of mental health, and also the comparison that they're doing of the people who had the shock during pregnancy compared to the people who had the shock slightly thereafter. Those groups are pretty comparable in terms of the mental health, average mental health of the two groups.
Thank you.
Thank you. It's probably time for one or two more questions or comments. Whilst people are thinking, I might ask a question. You mentioned the relative paucity of evidence around the relationship between adolescent health and adult outcomes. Why do you think there's far less evidence in that area compared to the relationship between evidence around the relationship between early childhood and adult outcomes? Because there are certainly cohort studies and administrative data that would allow a wealth of research to be done in that area.
Yeah, I think it's partly based on an assumption that you have to intervene in early childhood or all is lost. So I don't think there's a good reason for not looking at adolescence. I just think economists have kind of assumed that early childhood is where it's at, and that everybody's kind of jumped on the early childhood bandwagon. And I feel like I've been as guilty as anybody else of doing that. But just in terms of where marginal research would be most useful, we now have a lot of papers showing that having some disaster happen to you during pregnancy may have negative effects on your child. I mean, we have reports from Ukraine of women going into labor prematurely, given all the stress of being evacuated and so on. So we know that happens. We know a lot less, as Tao said, about effective interventions for adolescents. And so that's really an important area to look at.
Yeah. Well, thank you very much, Jenny. We've reached the hour. So thank you once again for your presentation, and thank you for all the participants for joining the webinar. We'll be advertising the next webinar in due course, and have a good rest of the day. Thank you. Thank you once again, Janet. Thank you.
Thanks.
Goodbye.
Bye.